Good afternoon / evening, everybody, and welcome to the Columbia Protocol training. My name is Austin Lucas, and I am the program director at the Ohio Suicide Prevention Foundation. I'm the guy that was sending all the emails with the event reminder. So I just wanted to welcome you all again to tonight's training presented by the Columbia Lighthouse Project in collaboration with the Ohio Suicide Prevention Foundation and the Ohio Department of Mental Health and Addiction Services. Before we go ahead and get started, just a couple of housekeeping items. If you do want to type any questions in the chat box as we go, feel free to do so. We will try to answer those in real time, but there will also be some time at the end as well to address any questions that come up. Also, this meeting is being recorded and we will be putting it on our website as well afterwards. And also, if you recall, I did send an email out yesterday with a last reminder about the Columbia Protocol community cards that you all should have received. Those who registered after the 15th may have not received theirs yet, just because we did send out that last batch for those that registered this week out yesterday. So if you did not receive your community card and you registered prior to June 15th, please send me an email. I will go ahead and put in the chat box for everybody to see your preferred mailing address, and we will get one out to you this week. But with that, I would like to welcome our trainer, Adam Lesser. Adam is the Deputy Director for Implementation at the Columbia Lighthouse Project. Adam is an Assistant Professor of Clinical Psychiatric Social Work in the Division of Child and Adolescent Psychiatry at Columbia University, Vagelos College of Physicians and Surgeons, and an adjunct professor in the Columbia School of Social Work. He is responsible for all project activities related to public health, including the international dissemination of and training on the Columbia Protocol. Previously, he was the Youth Suicide Project Director at the Georgia Department of Behavioral Health and Developmental Disabilities, where he directed the statewide implementation of the Columbia Protocol and other suicide prevention tools and efforts through the Garrett Lee Smith Suicide Prevention Grant from the Substance Abuse and Mental Health Services Administration. He has a master's degree in social work from Smith College and a bachelor's degree in economics from Tufts University. But with that, I will go ahead and hand it off to Adam. Thank you.
Thank you, Austin. Good afternoon, everyone, and welcome to our first of four of these trainings for the state of Ohio. Before I start, I always remind audiences that suicide is a very personal issue, and many of us are survivors who miss our friends or our family or our clients or coworkers. And so and some of us are attempt survivors. And so it's important to make sure that you take good care of yourselves and each other, because we don't spend enough time taking care of the caregiver. And if we don't do that, we run the risk of burning out, and we can't afford to lose all of you to burnout. So we know suicide's a global public health crisis. It actually kills more Americans than car crashes, more people across the world than natural disasters, war, and homicide combined, more soldiers than combat. It's the #1 cause of death in teenage girls across the globe. It kills more firefighters than fire and more police officers than crime. And we used to think that each death by suicide impacted, a few people, someone's family and close friends. But it turns out that each death by suicide impacts about 135 other people. And those effects linger, across generations because of the silence that often follows. Now, we know a lot about youth and young adults and their issues when it comes to suicide, because the Centers for Disease Control does the Youth Risk Behavior Survey every other year. And what students tell us year after year is that about 8% every year will attempt suicide. So if you're in a typical classroom of 40 kids, every year 3 of those kids will attempt suicide. It's usually 2 girls and 1 boy because girls attempt suicide twice as often as boys do, but boys die by suicide 4 times as frequently as girls. And there are a couple reasons we think for that. The first is that boys tend to choose a more lethal method when they make their suicide attempts. And they tend to choose firearms or hanging, and girls tend to choose overdoses with medication, which is much less lethal. But the other thing is that we see a lot more of the girls reaching out for help. And there's still a bigger stigma for boys and men in asking for help when you're feeling suicidal. And all of that makes it the second leading cause of death among youth and young adults between the ages of 10 and 34. And we've actually seen a more than doubling over the last 6 years in suicide of our youngest victims in the 8 to 12-year-old age range. Now, there's a strong relationship between suicide and school violence. The Secret Service did this study back in 2002 and found about 80% of school shooters had a documented history of suicidal thoughts or attempts prior to their attack. Over a quarter of them said suicide was their motive in making the attack. And only a third had ever had a mental health evaluation, with just 17% of them being diagnosed. So we've been saying since Columbine that if we start screening in schools, we may find kids, like Dylan Klebold, one of the Columbine shooters. He wrote in his journal, more than 3 times that he was feeling suicidal, and nobody knew to do anything about it. Now, as far as suicide deaths of adults, we lose about 46,000 adults to suicide every year in the US. But that's really just the tip of the iceberg when it comes to suicidal behavior and thoughts. We have about 1.5 million attempts every year. So there are about 25, on average, 25 attempts to every death. In fact, I learned recently that it's about 4 attempts to every death for the elderly population, about 25 attempts to every death for middle-aged Americans. And for teens, it's about 100 attempts for every death. So many more attempts in our teenage population than there are deaths. And as far as Ohio goes, you have the 22nd highest rate of suicide in the US. About 62% of your gun deaths are suicides. And your average death rates are about 2% lower than rates for the US in total. And in 2016, about 15% of your suicide deaths were veterans. You will be able to get a copy of this presentation if you registered for the training. I will make sure that Austin has a copy to send you. As far as method of suicide, in total, about half of your suicides are by firearm, with just over half of the men using a firearm and just over a third of the women using a firearm. And as far as regional clusters go, you've had clusters in the past in the Northeast and in the Appalachian areas of Ohio, as well as the major cities, Toledo, Cleveland, Akron, Columbus, Dayton, and Hamilton. And why in those areas? Some of the reasons we think are the socioeconomic disparities that occur in these areas, as well as low density of providers, especially in the rural parts of Ohio. And as far as Ohio students, they took the Youth Risk Behavior Survey last year or the year before in 2019. And what they reported was that close to 20% of the girls seriously considered suicide in the past year. 7.4% of the girls and 6.2% of the boys reported making a suicide attempt. 50% of the students identifying as lesbian, gay, or bisexual seriously considered suicide that year. And 30% of the male students identifying as gay or bisexual reported attempting suicide. And that was the highest group reporting making a suicide attempt. Now, there's a strong connection between chronic illness and suicide. Studies indicate at least 10% of suicide deaths are connected to chronic medical conditions. Young people, for example, who live with a chronic illness, such as inflammatory bowel disease, are 3 times more likely to attempt suicide than their healthy peers. 17 chronic medical conditions have been linked to increased risk for suicide, including back pain, cancer, epilepsy, migraine, sleep disorders. And in cancer, suicide is most common in the first 3 months after diagnosis. Overall risk is twice that of the general population and can be as much as 13 times the average risk in those newly diagnosed with cancer. So I'm going to save your questions until the end because I don't want to make this presentation too choppy. But please continue to write them in, and we'll go through them when we get done. Now, while the greatest numbers of suicides happen in cities, the highest rates of suicides are in rural America. There are a couple reasons for that. One, as I said, they have populations spread across great distance. Sometimes that gives them poor access to quality medical or mental health care. A lot of rural hospitals are shutting down. Sometimes it can take an hour for somebody to get to their local providers. And when it takes that long to get to a provider and you're struggling, someone's out of work, you don't spend the time or money to keep those appointments. The other thing about the rural parts of America is that if you track all demographic factors against rates of suicide, the one that most closely tracks are rates of gun ownership. The more guns you have in a community, the more deaths by suicide you're going to have, regardless of what else might be going on. And this data set makes that point very dramatically. This takes the states at the higher end of gun ownership rates and compares them to the states at the lowest end of gun ownership rates. And when you do that, in the states with the high rates of gun ownership, there are guns in just over half the homes. And you see about 8,000 non-firearm suicides in that group, very similar to the 8,700 that you see in the states with low rates of gun ownership for men. For women, about 3,500 in both groups. But you add the firearm suicides on top of that, and you add 4 times as many for the men, 16,000 compared to 4,000, and almost 10 times as many for the women, 3,000 compared to 300. So again, just living in a community where you have such quick access to a firearm is going to increase your risk of suicide, no matter what else might be going on in that community. Now, there's a strong connection also between addiction and suicide. We see opiates in about 1 out of every 5 suicide deaths, acute alcohol intoxication in about 1 out of every 4 deaths. Up to 40% of those who seek treatment for substance abuse have a history of a suicide attempt. And so if you have a diagnosis of an alcohol misuse disorder, you are about 10 times at greater risk for suicide. And if you're an injection drug user, you're at about 14 times at greater risk for suicide. And it turns out a lot of the opioid deaths that we've been seeing are in fact suicides, and they don't always get coded as suicides by medical examiners because they don't always know the motive. But a recent study by Dr. Maria Oquendo, president of the APA, showed that a lot of these deaths are in fact suicides. And it makes a lot of sense when you think about what gets people involved in opioid addiction is often a chronic pain problem that gets them their initial prescription from their doctors, or they may be self-medicating a mental health issue, right? So they may have depression or PTSD or anxiety, and they're using illegal drugs instead of the drugs that might be prescribed by a provider. And of course, we've seen some unintended results, consequences due to COVID. We typically see when the economy turns downward, we have an equivalent suicide rate increase compared to the income inequality that occurs. A survey in August reported about 40% of people had increased substance abuse, felt anxious or depressed during COVID. Over 10% reported suicidal thoughts in that survey. And this might be a good thing in disguise, but the National Crisis Text Line is getting 6,000 texts a week, which is double their usual amount. And more recent data from them showed that of the paramedics, nurses, first responders, unemployed workers, domestic violence victims, and grieving family, 80% came from people feeling lonely, isolated. 3/4 of them felt uncertainty about the future. Half had financial distress. And in March and April, SAMHSA's disaster distress helpline had a 1,000% increase in call volume compared to 2019. Now, I say this might be a good thing in disguise because people are actually calling and asking for help from these helplines, which is great. Now, for teens and youth in particular, studies of adolescents this year have found increases in depression, anxiety, and PTSD. In June, the CDC reported higher rates of ideation in teens at a time when they don't have access to their school-based mental health services. And in Texas, there were significantly more youth with ideation and attempts during March and July of last year, which were the same times that they had their peaks in COVID cases. Now, low-income families we see are being hit the hardest by COVID as well as by the mental health crisis. With less resources and access to care, rates of suicide and attempts have been rising faster among Black youth than among other race youth. JAMA Pediatrics reported children aged 19 were about 37% more likely to die by suicide if they were from communities where more than 20% live below the poverty line. And limited access to community support and lack of in-school counseling has also disproportionately impacted LGBTQ youth, especially if their family is unsupported. I saw a question a little earlier about transgender youth. They weren't singled out in the Youth Risk Behavior Survey, so we don't have data about transgender youth, or I didn't pull any data about transgender youth if it's there. Suicide's biggest cause, of course, you know, is a heritable, treatable medical illness called depression. About 85 to 90% of people who die by suicide have an untreated mental health problem. Most often it's depression. Depression is caused by changes in brain chemistry. It's the #1 cause of global disability. It costs about $300 billion globally a year. Suicide does. Depression costs about $1 trillion a year. Yet research on suicide and mental health is devastatingly underfunded, right? Suicide received less NIH funding than the West Nile virus, for example. And all of that makes this a vital part of health and wellness for employees and their families. You know, depression is the #1 cause of work-related absence. More people call out of work sick for being depressed than for any other reason. And that costs our workplaces about $23 billion a year in lost productivity from those folks. And we know that almost all of the cost of treatment for that depression would be offset by those productivity gains. And it's why we've been doing a lot of training lately for EAP programs. You saw on the slide here, Wells Fargo, Memorial Sloan Kettering, Amazon now, their EAP, it has been trained in using the Columbia tools. And the stigma is, of course, greater for folks who are doing these macho jobs that require you to be a strong, tough guy, being a first responder or in the military or a professional athlete. And interestingly, you don't have to be a man to have the higher risk of being in these professions. Women who are in the military, who are first responders, who are professional athletes, also have increased risk for suicide because of the stigma that surrounds asking for help. We were really pleased to see, not pleased for her sake, but pleased for the model that she represents, the professional women's tennis player, who recently took a break because of the mental health issues that she was going through. Hopefully that can be a model for others to ask for help. And shows like 13 Reasons Why just exaggerate and continue to propagate the misunderstanding about suicide. First of all, the title 13 Reasons Why. There are not 13 reasons why. The only reason why is that the main character had an undiagnosed and untreated mental health issue. And we know that suicide contagion because of exposure to suicide or suicidal behaviors in the media is very much of a problem, especially in adolescents and young adults. And we saw a spike in teen suicides in the month after Netflix premiered this teen drama. And, when the article came out that antidepressants are now the #1 prescription in the US, that didn't upset us. In fact, we're pleased by that. The fact that people are getting treatments they need is encouraging. And we worry more about undertreatment than we do about overtreatment. And all autopsy studies are of suicide, post-suicide, are associated with no treatment or non-compliance with treatment. And, about half of those who need treatment for depression or other mental illness are getting no treatment or inadequate treatment. 8 out of 10 adolescents or college students who die by suicide never got any consistent treatment prior to their death. And now during the COVID-19 crisis, many people can't afford or access their medications or if they're out of work. So let me debunk some myths about suicide. The first is that if someone's really suicidal, they're probably going to kill themselves at some point, no matter what you do. You can't stop someone who really wants to die. Multiple studies have shown that more than 90% of attempt survivors, including those who make very lethal attempts, don't go on to die by suicide. It's one of those symptoms of depression that comes and goes with your level of stress. And so if you help somebody through that time period when they're feeling their worst, they're most suicidal, you may actually make a lifelong difference for them. They may get some treatment and they may never become that suicidal ever again. And you may actually save that person's life, going forward. Asking a depressed person about suicide may put the idea in their heads. We know that this is false now. We used to worry a lot that if we talked about suicide, we would make it more likely that someone would do it, that same as that contagion effect. But it's actually, there are some very specific things that do trigger that contagion, and just talking about suicide does not. It doesn't suggest it or make it more likely. In fact, open discussion about suicide is more likely to be experienced as relief than intrusion. Of course, the bigger risk is when you don't ask these kinds of questions. Then someone making suicidal threats won't really do it. They're just looking for attention. We know that this is false, although there are some people who will say that they're suicidal quite frequently. They may have a wish to die that is their baseline, that just doesn't go away. This is common in folks who have borderline personality disorder, for example. We do need to take it seriously every time we hear about it. Even if we think they're just crying for help, a cry for help is a cry for help, so we need to help. There's no point in asking about suicidal thoughts. If someone's going to do it, they won't tell you. Many folks will tell a clinician when asked, although they might not volunteer it on their own. And they're often relieved because ambivalence is characteristic in 95% of people who are suicidal. You know, the wish to die that comes with being suicidal is fighting up against the human species instinct to survive. That survival instinct is actually very hard to overcome and make a suicide attempt. It's why we see about 80% will give some kind of hints or warnings to friends or family, even if they don't tell a clinician. And those hints or warnings can be, you know, very veiled and secretive. They can be just some post on Instagram about depression, but they can also be very blatant. We lost a youth to suicide who told his lacrosse teammates the night before that he was going to go home and kill himself after practice, and they didn't believe him or take him seriously. So we know people want to be asked because they tell us themselves. We do a lot of co-training with a man named Kevin Hines. If you've never heard Kevin tell his story, you should Google him and hear him tell it. He tells it better than I do, but he was a psychotic adolescent. He was 19 years old. He had a psychotic depression. It was telling him he had to die that day. And I'm sorry, he survived jumping off the Golden Gate Bridge, which is lethal 99% of the time. And that day, the voices were telling him he had to die. So he got on a bus to go to the Golden Gate Bridge. The whole way there, he's crying. He makes an agreement with himself that if just one person asks me what's going on, I'm going to tell them everything and I'll get some help. Nobody says anything on the bus. He gets to the bridge. He walks up and down the bridge a couple times. Nobody approaches him. Finally, a woman's coming towards him and he thinks, this is it. I'm going to get some help. And instead, when she gets to him, she asks him if he'll take her picture. So he takes her picture 3 or 4 times, gives her back her camera, decides that it's hopeless, and he jumps. And what he says is that instantly, as soon as his hands left the railing, he regretted his action and, you know, knew that everything in his life that he thought was unfixable was fixable except for what he had just done. And he says now in his talks that most people considering suicide want to be saved. They want someone to stop them. And what we need is a culture where no one is afraid to ask these questions. Then if you stop someone from killing themselves one way, they'll just find another. This is the argument for mean safety. Mean safety is actually the most evidence-supported suicide prevention measure we know. And what mean safety is when you can put a little bit of extra time in the way of someone who is feeling suicidal and them having the lethal means they're planning to use in their possession. And when you can make it take just a few more minutes, it gives time for that ambivalence to start to work. And when that ambivalence works, very often people change their minds. We have lots of examples about how mean safety has been effective in reducing suicide rates. In the United Kingdom, for example, all the way back in the late 1950s, they were using a very toxic gas in their stoves. It had a high carbon monoxide content, and people were dying there by asphyxiating themselves with their cooking gas. It's where the expression "put your head in the oven" comes from. And they started phasing that out, replacing it with natural gas. And they saw their suicide rates by carbon monoxide poisoning cut by 1/3 without much of an increase in any of the other methods. So when people couldn't do it that way, they didn't go and look for another way. Then in England again in 1998, they were having a problem with Tylenol overdosing. So they passed a rule there where Tylenol has to be sold in blister packs, where you punch out one of the pills one at a time, like we do for antihistamines, for example, Sudafed. And when they did that, they reduced Tylenol overdoses by 44% over the next decade, right? We sell Tylenol here in the US in bottles of 500 at Costco and BJ's, right? Sam's Club. We don't have the same effort at making it a little harder to get a lethal medication as they've done in other countries. And then lots of examples about how making it just a little bit harder to get a firearm actually saves lives. In New Zealand in 1992, they passed a mandatory lock law and reduced gun suicides by youth by 66%. And in Israel, in the military, they recognized they were having a problem where their military personnel were dying by suicide when they were home on leave. And so they made a rule where when their military officers go home on the weekends, they can't take their guns with them now. They have to leave them on base. And when they do that, and they don't have them when they're struggling with their family issues, their financial issues, when they're dealing with their spouses and their kids, and they don't have a gun handy, they were able to reduce their military suicide rates by 40%. So we're trying to put the Columbia questions everywhere people acquire means. So we've trained subway platform workers. There's a program that brings the Columbia questions to pharmacy students in pharmacy college. We've delivered these community cards to gun shops. Gun shop owners, by the way, are really excited to have these kinds of tools because they don't want to sell a gun to someone and then find out the next day they used it to kill themselves and that they left, a spouse without a husband and kids without a father. They feel terrible about that. So they're happy to put these things out for folks who might take them and then might recognize depression, in a loved one. And all of this is a move away from the medical model towards a public health model when it comes to suicide prevention. We used to take a very medical model approach to suicide prevention, where it was a very narrow approach where we did targeted screening of folks in high-risk groups. We treated folks and trained mental health providers how to identify and how to treat suicide and depression. But the problem, as I told you, is that the majority of people we lose to suicide aren't seeing anyone for specialized treatment, right? So we now know that we have to go to where they are and take a broader approach. This public health model involves universal screening and targeting a whole community with training. So teachers, community counselors, religious leaders, law enforcement, first responders, even interested parents and teens can have these questions and are able to ask and identify someone who's at high risk and escort them to get the care they need. That's where the community cards come in so handy. And we learned this from the US Marines. They were the first branch of the military that came to us for training, but they didn't ask us to train their mental health staff. They asked us if we would train their financial aid counselors, their clergy, and their lawyers, because the number one precipitating event before a Marine suicide was having a legal problem. They'd get arrested for a DUI or a domestic violence charge, and they were ending their lives by suicide because of the impact that can have on their military career. And so now in the Marines, every time a lawyer meets with a Marine, the lawyer screens with the Columbia screener and then escorts them to behavioral health if they're worried about them. So we believe everyone everywhere can and should ask these questions. Vermont, for example, has a policy recommendation for schools that everyone from the janitors on up to the superintendents go through training. Because we know, as our friend Kim Ruoko from the Tragedy Assistance Program for Survivors says, she lost her husband, who was a Marine pilot, to suicide, that Marines may not go to their leaders to talk about this, right? But they may talk to a bartender or their personal trainer at the gym. And so everyone in a community needs to know how to screen for suicide risk. And again, this is what we have in the way of community cards. We have lots more, but this is a sample of them. They can have a different front with a different picture for different groups, populations, but they all basically have the Columbia screening questions on the back. And then you can tailor the front for whatever group you're working with. And the Air Force has gone the farthest towards this whole system-wide approach, and they actually brought suicide rates down farther than any other of the branches of the military. But they not only had training for their behavioral health staff and their schools, their primary care folks. They gave one of those community cards to every airman and their spouse so that they can watch out for their battle buddies and they can watch out for their loved ones. So I'm going to show you a training video demonstration that was made by the chaplains in the Air Force for their internal training. It'll give you a flavor of hearing the questions on the screener being asked. I warn you that he does get into asking about death very quickly, and it can be kind of abrupt and jarring. But we didn't want to take, any more time having him sort of ease his way into the questions. And so, for the sake of the training video, he just jumps right in. But know that you would, take a little more time if you were doing it.
Oh,
Airman Powell, hey, how's it going? You look frustrated.
yeah, I'm just trying to even.
Yeah.
Let's work.
How did it go? I knew you were looking forward to that leave with your family. How'd that go?
Yeah, I was. Wish I was still on leave just so I had more time, but
You're pretty frustrated, huh?
it was, yeah, separating soon and just being back home, it just made things more difficult, and I don't know, it's whatever.
Yeah. You don't really look yourself, Maybe, you mind if I ask you a few questions?
Yeah, that's fine.
Do you wish that you were dead, or that you could go to sleep and just not wake up?
I mean, yeah, going to sleep, that sounds pretty good.
So, have you actually had any thoughts of killing yourself?
Yeah, I have.
Well, thanks for being honest with me about it. So have you been thinking about how you might do this?
Oh, I have this gun at home, so
Yeah.
I mean,
Have you had some intention to act on these thoughts?
I don't know. I clean it and I'm sitting there with it for a while and just I don't know. Things creep into my head and I don't know.
Have you started to work out or worked out the details of how to kill yourself?
I mean, other than sitting there holding it and maybe using it, I don't know. It would be so easy.
Right. And thanks for being honest with me. Do you intend to carry out this plan?
No, I think about it sometimes, but...
So have you done anything, started to do anything, or prepared to do anything to end your life?
No, not yet.
Well, thanks again for being honest with me. I know you're having a tough time right now. I can tell that. And I'm concerned about you. I think we should go talk with somebody, make sure that you're squared away. How does that sound?
Yeah, I guess so.
Okay.
Come on.
Sorry, I was muted there for a second. So it takes just that long, a couple minutes to do the Columbia. So screening. We know screening programs work because we've seen studies that prove it. John Mann did a meta-analysis and concluded that screening results in lower suicide rates in adults. It better detects depression in the elderly population. This high school screening program for suicide identified more students who had significant mental health issues than relying on the school counselors to go out and find them on their own. And when they used both screening and the school counselors to find them, they did even better. And this college screening project is a very interesting one. This was done at Emory. What they did was they sent an electronic version of the Columbia to every incoming freshman. And they didn't ask them to turn in their answers. They just told them that these are the high risk answers. And if you're answering yes to these questions, please, come to the counseling center. And what they found was not only did they have fewer suicides in the 4 years post-screening compared to the 4 years pre-screening, they also noticed that more students came to use the counseling center when they were stressed out. So it created this warm connection between the students and the counseling center, and let them know that it's okay to talk about suicide, right? We're here to talk about suicide if that's an issue for you. And that's very important. And so we need to ask these questions the same way we monitor somebody's blood pressure, because we have lots of opportunities to screen that we're not taking advantage of. You know, nearly half of people who die by suicide see their primary care doctor in the month before they die. And 2 out of 3 adolescents who have attempted suicide and are in the emergency room are not there for a psychiatric issue. So imagine if every school nurse, physical therapist, EAP was asking about mental health alongside with the physical checkups. You know, if we asked, we would hopefully find more of those people who are suffering in silence. So first we have to accurately identify, and that's where the Columbia tools come in. The Columbia screener was developed as part of an NIMH study looking at adolescent suicide attempters. It's the first scale to assess the full range of ideation and behavior. It was done at Columbia and at University of Pennsylvania with Aaron Beck's group there. It's available in over 140 languages, is used in millions of locations. It's considered the most evidence-supported suicide risk assessment measure that is out there. We hear excellent things about acceptance of the questions by patients and by providers. It can be used across all ages. The standard Columbia is used for ages 6 on up to 106. And it can be used for special populations such as Alzheimer's and autism. As you'll see, we'll talk about that in a little bit. Now, the definitions that the Columbia uses were picked up and also are used now by the CDC. But the CDC in this document for researchers that links to the Columbia for definitions also has a list of the things we should stop saying. Things like completed suicide and successful suicide or unsuccessful suicide, right? You complete a project and you're successful at your job, and we want to take positive words like that away from an act like suicide. Likewise, survivors have told us that they would prefer it if we did not say committed suicide, because it makes them feel like their loved ones committed a crime, because that's the most common use of the word committed. So the recommended language now is to just say died from suicide or ended one's life by suicide, and to keep out any of the sort of descriptive language that goes along with it, and to just be very straight and forward about it. Now, the Columbia is part of the National Action Alliance's Toolkit for Zero Suicide. The Toolkit for Zero Suicide is for healthcare environments, and Centerstone, which is one of the nation's largest providers of outpatient behavioral health care, is the model agency for this. And what they do is they screen every single client every time they see them. So if a client comes in and sees their psychiatrist for med management, and then goes and sees a case manager, and then goes to group therapy, they'll get screened 3 times that day, right? And you'll see how easy it is to do screening 3 times a day when we get to the questions themselves. If they screen as positive, they get placed into a suicide-safe pathway of care, where their name changes color on their electronic health record, so all the providers working with them know this is someone in that safe pathway of care. They get weekly appointments, they get education on means restriction and a safety plan. If they don't show for an appointment, they attempt to follow up by phone call, and they have dedicated follow-up specialists who continue to reach out to that person by phone until they can re-engage them and get them involved in treatment again. Now, they report that they had a 65% reduction in suicides in the first 20 months that they initiated this program. The Columbia is a semi-structured interview. There are questions provided, but it's not required that you ask any or all of them, just enough so that you've collected the information to go back and mark the right areas, knowing whether to call an event suicidal or not. Now, you can use multiple sources of information to fill out the Columbia. This is one of the real benefits of it, and why it's used often in folks who have Alzheimer's or autism, is because when those patients get to a spot where they are unable to respond, you can use the reports of their caregivers or their loved ones, right? Any source of information that gets you the most meaningful answers, what you think are the most accurate answers, whether that's the person themselves, family members, medical records, those are that's the information you'll use to fill out the Columbia. This can also be very helpful for children or adolescents whose parents may give you different information than the kids give you. Now, the Columbia is just an assessment of suicidal ideation and behavior. There are two versions of the Columbia. There is the screener version of the Columbia, which is the 6 questions that are on the back of the community cards. And there's a fuller 10 to 25 question version of the Columbia, which is used for assessment after screening is positive. If you're doing either of those two versions, the first 5 questions are exactly the same. They are questions about ideation severity, and they increase from a wish to die to an active thought of killing oneself with plan and intent. Then if you're doing the full assessment version, you have 5 follow-up questions on the intensity of those thoughts. And then we have behaviors in both versions. And both versions get at finally all the relevant behaviors. It used to be we only asked about past suicide attempts. And when that was the only behavior we asked about, we were missing people who practiced how to tie a noose, or who looked up ways online to kill themselves, or put a noose loosely around their neck and then change their mind. Things that we know now have just as much risk for someone who's going to make a suicide attempt in the near future as having made an actual attempt, but are things we never used to ask people about. And there are standardized questions and definitions right on the Columbia forms to guide you through the most the simplest identification. Then if you're doing the full assessment version, again, there's a final question on any medical damage that happened from actual suicide attempts. And we'll look at these all individually. So ideation, this is what the full assessment ideation page looks like, 10 questions. They start with the same first 5. Have you wished you were dead or wished you to go to sleep and not wake up? Have you actually had any thoughts of killing yourself? If you answer question 2, no, you skip 3, 4, and 5. But if you answer question 2, yes, you'll ask, have you been thinking about how you might do this? Have you had these thoughts and had some intention of acting on them? Have you started to work out or worked out the details of how to kill yourself? And did you intend to carry out this plan? You can't have a method in mind or intent to act if you've never had thoughts of killing yourself before. So that's why you can skip them if question 2 is no. Somebody asked where they could get the fuller version of the Columbia. You can download it right from our website. And if you have trouble finding it on our website, you can just contact us and we'll send it out to you. But they are on our website, which is CSSRS.columbia.edu. And I'll put it up at the end again for you. So let's see another demonstration video of someone asking these first 5 questions.
So tell me, what brings you to see me today?
I've been feeling kind of crummy, problems with my family, and things at work aren't going so well.
Have you been feeling depressed?
Oh, I've been crying a lot, and it's hard to get out of bed in the morning. I guess you could say I'm depressed.
I see. So tell me, over the last month, have you wished you were dead or wished that you could go to sleep and not wake up?
Sometimes I think things would be better if I were dead.
I understand. But do you actually wish you were dead or want to be dead?
Now and then, yeah.
And have you actually had any thoughts of killing yourself?
Yeah.
And have you been thinking about how you might kill yourself?
Sometimes I think about jumping in front of a train or a bus.
But you wouldn't really do that, though.
No way, no way.
See how asking the wrong question can shut down the conversation? Watch now how asking the right questions using the prompts on the CSSRS can get you more accurate information.
Sometimes I think that I'll jump in front of a train or a bus.
Have you had these thoughts and had some intention of acting on them?
Yeah.
Can you tell me a little more about that?
Last week I really wanted to do it, but I chickened out.
Okay, so have you started to work out or worked out the details of how to kill yourself?
No, nothing specific.
Thank you for being so honest with me.
Thank you.
So in the example you just saw, the answer circled would be a 4, intent only, not intent and a specific plan. In this next example, a 5 would be indicated. Watch.
Sometimes I think that I'll jump in front of a train or a bus.
Well, have you had these thoughts and had some intention of acting on them?
Yeah.
Can you tell me a little more about that?
Last week I really wanted to do it, but I chickened out.
Okay, so have you started to work out or worked out the details of how to kill yourself?
Yes. I got a subway schedule and I saw that there's a station that between 7 and 8 o'clock at night, there aren't many people there, and that's what I was going to do.
Well, do you intend to carry out this plan now?
I worry that I might.
Okay. Thank you for being so honest with me. We're going to get you some help right now.
Thank you.
You see, it would be a 5 because he had intent and a specific plan with the intent to act on it, all the details worked out, etc.
Okay, so if you're doing the full version, you have 5 follow-up questions. And those are based on the time they felt the worst in the first section. And they're questions about the frequency of the thoughts, the duration of the thoughts, how controllable are the thoughts, do they have deterrence to acting on their thoughts, and what are the reasons for the thoughts? Is it to stop the pain they're feeling or to make something else happen? And so logically, if thoughts are more frequent, if they last longer, if they're impossible to control, if they have no deterrence, and if it's to stop pain, you would worry more about someone. You can add up the answer numbers for this section and you'll get something between 2 and 25. But we don't have scientific cutoffs for risk for this section. So it can give you some more information for your clinical judgment to help inform your clinical judgment. But it doesn't appear on the short screener because we don't have that scientific cutoff for imminent risk like we do for the first 5 questions. And of interest, if you do work with teens, Cheryl King did some research and found that the second question on duration is the most predictive question for adolescents. So if an adolescent is having suicidal thoughts that are lasting all day long, they can't get it out of their heads, it's playing over and over and over again, that's when you would worry most about an adolescent. To answer a question that came in, how necessary is the line, "Thank you for being honest with me"? It is not necessary at all. But I wrote all the scripts and it just comes in my vocabulary. But you do not have to say that. The behavior section, on to behavior. The behavior section asks about 4 specific behaviors. The first being an actual suicide attempt. And the definition that we use and that the CDC and DOD now use are that a suicide attempt is a self-injurious act undertaken with at least some intent to die as a result of the act. And there are a few important parts there. The first is that it says a self-injurious act. It doesn't say self-injury. There doesn't have to be any actual physical injury and it qualifies as a suicide attempt. So if somebody puts a gun to their head and the gun fails to fire because it's broken or trigger jams, As soon as they pull that trigger and there's potential for injury, it becomes an attempt. Then it says at least some intent to die, as long as intent to die is non-zero, but it does not have to be 100%. So a lot of times when people make suicide attempts, they have mixed motivation. And so if part of them wants to die when they do it, but part of them wants to make people take, be aware of how bad they're feeling or make someone else feel bad, as long as there's a little bit of intent to die, then it's a suicide attempt. And then it says as a result of the act, meaning that the intent to die and the behavior have to be connected. They have to be doing that behavior because they want it to kill them in some part. Now, you can infer intent with the Columbia. You can do that if someone denies that they were intending to kill themselves, but they know that what they did could be lethal and they did it anyway. Or if in what we call clinically impressive circumstances, that's where what someone does is so highly lethal that you couldn't mistake it for anything else. That's someone who shoots themselves in the face or jumps from a high story or takes 200 pills. Now, the reason why we go through this definition very carefully is that we're trying to oppose it to non-suicidal self-injurious behavior. Non-suicidal self-injurious behavior happens more frequently than suicide attempts. And it's when someone engages in self-harm behavior and it's 100% for reasons other than ending their life. It's usually either to affect how they feel on the inside, so they're feeling pain and hurt, and self-harm behavior helps to release that pain, or they're feeling numb inside, and those self-harm behaviors release adrenaline, which makes them feel alive and in the present, or to affect external circumstances. That's the person who wants to get sympathy from somebody, or attention, or make someone angry, so they pretend that they're suicidal. Now, the other three behaviors that we never asked about are an interrupted attempt, which is when someone starts to take steps to end their life, but someone or something stops them. So for example, someone has a bottle of pills or a gun, but someone grabs it. Someone told me about a woman who was attempting to hang herself and her dog kept getting in the way. So we would say that that was interrupted by the dog. Or then we have self-interrupted attempts. That's when someone starts to take steps to make an attempt, but before they do anything that has potential for injury, they change their mind. That's the person who's planning to drive off a certain cliff and halfway there, they turn around and come back home. Or they're climbing the stairs, but change their mind and come back down. And then finally, preparatory acts or behaviors. That's any other behavior beyond the verbalization that has suicidal intent. So things like acquiring the means you're going to use, giving away your valuables, writing a suicide note, looking up ways online to kill yourself. And like I said, we think that by asking about all types of ideation and behaviors, maybe we can find kids like Dylan Klebold. He actually mentioned more than 5 times in his journals that he didn't fit in, and thinking about suicide gave him hope. Likewise, the Santa Fe shooter wrote in his journals that he wanted to kill people and then kill himself. Now, all of these behaviors are prevalent. In fact, the 3 behaviors that we never used to ask about are actually more prevalent than actual attempts. So this is a look at 30,000 administrations of the Columbia, and of the 1.7% of worrisome answers, 87% of those were those other 3 behaviors, and only 13% were actual attempts. So if we don't ask about those other 3 behaviors, we're going to miss the majority of people that we need to worry about. Then the final section on the full version is lethality. That's for any actual attempts, how much medical damage occurred. And you'll just ask a few questions to find out about how much medical attention they got, and you'll be able to pick one of these answers. And the final question is on potential lethality. And so that's only if an actual lethality answer is 0, you would answer this, and it's where you can mark what would happen if they tried the same exact type of attempt again. What's the likely outcome? This is there because those rare cases where someone does pull a trigger on a gun and the gun fails to fire, you want a place where you can very quickly see that even though medical damage was 0 for that attempt, it's really likely that it will kill them the next time. It's a very lethal attempt, even though the medical damage was 0. So let's watch somebody asking the behavior questions. And I promise you, she will say, thank you for being honest with me again.
Have you made a suicide attempt in the past 3 months?
No, not really.
What do you mean by not really? Have you done anything to harm yourself?
Well, last month I took a handful of pills because it's like even my parents can't see how much pain I'm in.
Did any part of you want to kill yourself? Or was it 100% to get them to pay attention to you?
I guess a little bit of me wanted to die. Either way, I would have been better off.
Were there any other times you did something like that?
No.
Okay, I see. And in the past 3 months, have you ever started to do something to end your life? That someone or something stopped you before you actually did anything?
A friend of mine took a bottle of pills from me because I was thinking about taking them.
Was there any other time that happened?
No.
Okay. And has there been a time when you started to do something to try to end your life, but you stopped yourself before you actually did anything?
No. Not that I can remember.
Have you taken any steps toward making a suicide attempt or preparing to kill yourself, such as collecting pills or getting a gun, giving valuables away, writing a suicide note?
I wrote a note to my friend telling her that she could have my CD collection if anything ever happened to me.
Is that the only thing you've done like that?
This one time, I put a bottle of pills underneath my pillow. You know, just in case.
So, just those 2 times?
Yes.
Thanks. I appreciate how honest you've been. So, when you took the pills, what happened after that? Did you go to a hospital? Did you seek medical attention?
Well, they were just vitamin pills. So no, I didn't get any medical attention.
I see. Thank you. Let's see if we can get you some help.
Thanks.
Okay, so when you're doing the behavior section, you'll check all the behaviors that apply, but only if they're discrete behaviors, part of a discrete episode. So for example, if someone wrote a suicide note, collected pills, and then took those pills, you wouldn't count that as 3 separate things. You would just count that as one suicide attempt, because we don't want people to look more densely suicidal than they in fact are. Also, remember, you have to ask about behavior, even if the ideation questions are all no, because we have seen occasional folks who will say that their suicide attempt was so impulsive that they never thought about it before doing it. And it's important to listen to what the person believes was going to happen based on their behavior and not what you think about the lethality of it. This is very important for very little kids who may do things that seem silly, but if they're saying they want to die when they're doing it, it's a suicide attempt. Also for folks who might be psychotic, might come up with some strange ways to kill themselves. We have to take it at face value that if they say that they wanted to kill themselves, that's what we would call it, a suicide attempt. So on the screener, all 4 of those behaviors are rolled into one question. Have you ever done anything, started to do anything, or prepared to do anything to end your life? And there are examples right on the form of all 4 of the behaviors. Now the time frames are really important. So for the full scale, we have what we call the lifetime recent version, which has 2 scoring columns, one for lifetime, which is the time they felt the worst or the most suicidal, and recent. Recent tells you about what's their risk today. And to figure out their risk today, we want to know about the past 1 month of ideation and the past 3 months for behaviors. The authors found that after those windows of time, the risk for an imminent suicide attempt drops by more than 50%. So those are the timeframes you'll ask about. And we also have on both the full and the screener a version of for monitoring called the since last asked or since last visit version. And it's because it's as simple as saying to someone, since I last saw you, have you had any thoughts about suicide or done anything, started to do anything, or prepared to do anything to end your life? That's questions 2 and 6. Those are the important questions that would trigger a more thorough interview if either of those questions were yes. But so when you're doing follow-up with someone after you've already done the initial, this is all you would need to ask. And it's why they can do it so frequently on inpatient units or at Centerstone and other outpatient providers. So who do we worry about? We worry about a yes to question 4, 5, or 6. If they've had intent to act on their suicidal thoughts within the past month, or they've had any of the 4 behaviors within the past 3 months, they are at high risk. They need to immediately be assessed for possible hospitalization by a mental health professional. And if you're doing the full version, it's the same thing. A yes to question 4 or 5 in the past 1 month time frame, or a yes to any of the 4 behaviors in the 3 month time frame. And no matter who uses it, it's the same risk answers. The next steps will change based on where you're doing this. If you're in a school, you'd have different next steps perhaps than if you were on an inpatient unit. But what triggers the highest level of intervention is a yes to question 4, 5, or 6, no matter where you are. So let's see how somebody uses it to rule out going to the ER, which is one of the biggest benefits of the scale.
I've been in situations like this before where it was really hard to tell if someone was actually in danger of suicide or not. Fortunately, I was recently introduced to CSSRS, and I could use a few quick questions to help me decide what level of care she needed. Hi, are you Joan?
Uh-huh.
I'm glad you called us. We're gonna get you some help, okay?
Okay.
I'm gonna ask you a few questions about your thoughts and behaviors over the past few weeks to help us better understand how to help you. Is that okay?
Okay. Am I gonna have to go to the hospital?
Let's just get all the information about what's going on first, and then we can talk about that, all right?
Okay.
Good. Have you wished you were dead or wished you could go to sleep and not wake up?
Yeah. I wish I was dead right now.
Have you actually had any thoughts about killing yourself?
No, I would never do that.
Okay. Have you ever done anything, started to do anything, or prepared to do anything to end your life?
I mean, once when I was a teenager, I wrote a note to my friend saying I wanted to die, but nothing recently.
Okay, thanks.
Okay, he didn't say thank you for being honest. So she said yes to question 1, no to question 2. So he skipped 3, 4, and 5. And then he asked her question 6, and she said, yes, I had a behavior, but it was a long time ago. So this is someone who doesn't need to go to the hospital. This is someone who he could say, do you have an outpatient provider? Can we give them a call, get you an emergency visit? If not, can we connect you with a community provider? Here's the suicide hotline number. I want you to have this with you. Do you have a friend or family member you can spend the afternoon with so you don't have to be alone? But this is someone who doesn't rise to the level of going to the ER. And this is preventing a lot of unnecessary ER holds, a lot of congestion in the ERs. and we know that when someone is assessed in an ER and it's unnecessary, it actually shuts them down to treatment when they do need it. So they're less likely to go follow through with the treatment plan if they've been taken to the ER when they don't need to really be there. We have a flexible toolkit, so there is a checklist of risk and protective factors that the authors developed that you can use with either the screener or the full version. It's part of a more thorough assessment, and you can download that off our website as well. And you can add your own questions to the Columbia. So if there are risk factors that are specific for your population you're working with, feel free to add a cover page with those questions. You can ask any additional questions that you think might help inform your clinical judgment. Because we're never going to have a perfect system, right, for figuring this out. There's always going to have to be some clinical judgment involved. We have, some indicators, some good indicators, but you still need to use clinical judgment because things might have gone on that have mitigated the high risk, and they may not need to go to the ER even though they've had a behavior within the past 3 months, for example. They may be in treatment and on medication and stabilized. So you have to use your clinical judgment. You can't just go on what the Columbia spits out. And so it's just as important to have flexible and innovative delivery as it is to have the right questions. So you can put posters with the questions on it. You can use it in telehealth. You can put it on your ID badges like they've done at the University of Tennessee. We've been in talks with Amazon, who an executive there said, wouldn't it be great if we could put them on the boxes so that everybody could see them. We have an app for iPhone and Android. If you go to the App Store and you search on Columbia Protocol, you'll access the app, and it just gives you the 6 questions and then tells you whether you're at imminent risk or not. And if you're at imminent risk, it says to, please call the crisis center or 911 and don't stay alone. As you can imagine, this is having a huge impact on care delivery because we're finally getting the right people. We used to use a scale called the PHQ-9 for assessing suicide. It's a Great Depression assessment. And in fact, it's the best depression assessment that we have. But the 9th question on suicide is a really poorly worded question. It says, have you had thoughts you would be better off dead or of hurting yourself in some way? Now, better off dead is actually not considered suicidal by suicide researchers. It does not increase your risk of suicide. And hurting yourself in some way can be non-suicidal self-injury. So you get a lot of false positives. In fact, this study found 24% of these patients at Cleveland Clinic endorsed item 9, whereas it was just 6% when they screened with the Columbia. This is what happened at Reading Hospital. The blue line are the levels of psych consults in the ER after initiating with the Columbia, screening with the Columbia, and the red line are the average psych consults before screening started. And they found their psych consults were lower in every quarter after they began screening. And you don't need to be afraid of doing universal screening because you're not going to be inundated with the numbers of people who are at high risk. Parkland is the first hospital to do universal screening in Parkland in Dallas, Texas. And they reported after their first 100,000 patients screened that they had 1.8% positives that they had to follow up with. And when the Connecticut National Guard did it as part of their periodic health assessment, they have now over 38,000 screenings and were able to identify 17 soldiers who needed assistance. So less than 1%. So you'll see about 1 to 2% of folks will give you positive answers. This was a VA hospital in Detroit where they screened 3,000 vets who were seeing a psychiatrist, and they were able to find 14 that screened positive, 0.5%. And of those 14, 5 needed to be hospitalized. So again, they found 5 vets that they wouldn't have found otherwise, relying on their usual tools. And you know, this can actually provide you with some liability protection because it is considered the gold standard suicide risk measure. You have more liability when you do nothing or when you use a tool that somebody else came up with and you don't know what the origin is and you don't know if there's any science behind it. Doing the Columbia, as someone said, you know, gives us something to hang our hat on. It can also provide us with some internal liability relief, right? It allows clinicians to sleep better because they know that they did the best tool out there and they did their due diligence. And we can't underestimate the magnitude of connecting and using a common language, which the Columbia provides. You know, loneliness has devastating health effects that a study recently showed were equal to having 15 cigarettes a day, which makes it more lethal than heart disease and obesity. And so the Columbia Protocol is more than just a method to identify when someone's at risk. It's actually a framework for normalizing tough conversations around suicide and reducing stigma. And this promotes connectedness. Just giving someone the Columbia tool, sharing it with them, asking them the questions, actually can break through that isolation that folks who are suffering from depression have, and can really make a difference just in being able to connect with that person. So this is how you can reach out to us. We do still have 10 minutes for questions. If you want to type them into the chat, that would be great. You can email us though at kelly.posner@nyspi.columbia.edu, or go to our website and fill out a contact us form. All of these emails I'll see and probably respond to, but you're welcome to write us with any questions that you have, especially after you start using it or you start writing policy. We're happy to consult with you on any policy that you write, help you to put it into your electronic health record by checking the accuracy of the build that your EHR team does.